Assessment of aortic valve disease is a common referral to the echocardiographic laboratory. The addition of Doppler techniques to standard two-dimensional imaging permits non-invasive assessment of the hemodynamics of aortic valvular dysfunction. In particular, the ability for the echocardiographer to accurately determine the severity of aortic stenosis is having a profound impact on clinical management of these patients. In this tape, we will first discuss the 2D diagnosis of congenital abnormalities of the aortic valve. This will serve as a lead-in to the echocardiographic assessment of aortic stenosis, and we will conclude with a discussion of the utility of 2D and Doppler in aortic regurgitation. Congenital abnormalities of the aortic valve are best diagnosed utilizing the peristernal short axis view. You will recall from tape number 1 that the cusps of a normal aortic valve form a letter Y configuration in diastole. This is the left coronary cusp, right coronary cusp, and non-coronary cusp. In systole, the three cusps separate at the commissures, resulting in a triangular orifice. Before making a confident diagnosis of three-cusped valve, this systolic triangle must be identified. This specimen is a bicuspid aortic valve, which is one of the most common congenital anomalies. In a Mayo Clinic series of 21,417 necropsies, Drs. Eric Larson and Bill Edwards found a 1.37% incidence of bicuspid aortic valve. Note that the two large cusps are quite redundant. This ridge of tissue is a raphe, a frequent finding with bicuspid valves. This is a peristernal short axis view of a bicuspid aortic valve. Although there are only two commissures, here and here, the raphe gives the valve a Y appearance in diastole, mimicking a three-cusped valve. In systole, it is apparent that the point at 1 o'clock represents a raphe rather than a true commissure, because the anterior cusp opens as a solid, complete structure and does not split at the raphe. The commissures can now be confidently identified at 10 o'clock and 5 o'clock. The valve orifice has an oval football or fish mouth appearance. The location of the commissures may vary from patient to patient, but this is the most common orientation. Regardless of the orientation, the diagnosis of bicuspid valve is made by demonstrating the oval systolic orifice. Congenitally unicuspid valves are stenotic from birth. In the previously mentioned necropsy series, the incidence of unicuspid aortic valve was 0.075%. This is the single commissure, and the single cusp extends around the entire aortic circumference. Unicuspid valves open with a doming motion. In short axis, note that the orifice is small and eccentric. This is a peristernal short axis view of a unicuspid aortic valve. In systole, note the single commissure and the eccentric orifice, which has a teardrop appearance. Even less common than the unicuspid aortic valve, this is a quadricuspid aortic valve. In their series, Drs. Larson and Edwards found a 0.014% incidence of quadricuspid aortic valve. 3 of the cusps are normal-sized and in their usual locations, while the extra cusp is much smaller. These valves are frequently insufficient and may also have an increased tendency to calcify and stenose. This is the parasternal short axis view from a patient with a quadricuspid aortic valve. This is the left coronary cusp, and this is the right coronary cusp. There are two non-coronary cusps, one in the usual position, and this small extra cusp. In systole, all four cusps have opened. Because the fourth cusp is so small, the valve has a triangular appearance. This is another example of quadricuspid aortic valve. Here the four cusps are of approximately equal size. Therefore, in diastole, the valve closes with a letter X appearance. Using a frame grabber, we have now captured and simultaneously displayed the opening motion of a normal three-cusped valve, a bicuspid valve, a unicuspid valve, and a quadricuspid valve. The unicuspid aortic valve is intrinsically stenotic and also has a tendency to calcify even as early as the second and third decades. Bicuspid aortic valves also tend to fibrose and calcify, with stenosis resulting most commonly in the fifth and sixth decades. This is rheumatic aortic stenosis. Note the commissural fusion. This was once the most common cause of aortic stenosis, but the incidence has declined. Currently, the most common form of aortic stenosis is the so-called senile variety, in which heavy calcific deposits form on the leaflets of a three-cusped valve. In assessing patients with aortic stenosis, we utilize two-dimensional echo to establish the valve morphology, to determine the extent of calcification, and to assess valve mobility. 2D echo is also useful for assessing the degree of left ventricular hypertrophy and for determining left ventricular systolic function, while Doppler echocardiography is utilized for assessment of hemodynamic severity of aortic stenosis. This will be discussed in further detail. This is a heavily calcified aortic valve in short axis. Often, as in this case, the degree of calcification obscures the valvular architecture. The valve clearly demonstrates reduced mobility, but scanning the valve fails to reveal an orifice that can be traced. 2D echo alone is not sufficient for confidently determining the severity of stenosis. Continuous wave Doppler interrogation of the stenotic aortic valve yields an accurate assessment of the pressure gradient across the valve. In this case, an apical transducer location is being utilized. The maximum velocity is 5.2 meters per second. From the simplified Bernoulli equation, we know that this velocity corresponds to a maximum instantaneous pressure gradient of 108 millimeters of mercury. It is important to understand the difference between Doppler maximum instantaneous gradients and Cath peak-to-peak gradients. The peak-to-peak gradient is used as a marker of severity of aortic stenosis by many catheterization laboratories. This has come about through convenience. The peak of the aortic pressure is simply subtracted from the peak of the left ventricular pressure. You will note that the peak-to-peak gradient is a non-physiologic parameter, representing non-simultaneous events because the peak aortic pressure occurs later than the peak left ventricular pressure. On the other hand, the maximum instantaneous gradient, which is derived from the maximum Doppler velocity, is a physiologic gradient, representing the maximum instantaneous difference between the left ventricular and aortic pressures. Remember that the maximum instantaneous gradient will always be greater than the cath peak-to-peak gradient. The mean pressure gradient is the sum of the instantaneous gradients occurring throughout systole divided by the systolic ejection time. The mean gradient between left ventricle and aorta can be precisely determined from the Doppler spectrum. This is the gradient that we highlight in our report to referring physicians. The mean gradient can be determined by selecting multiple velocity points along the Doppler spectrum and converting each velocity point to a corresponding instantaneous gradient utilizing the Bernoulli equation. You then simply sum these instantaneous gradients and divide by the number of data points to arrive at the mean gradient, which in this case is 75 millimeters of mercury. Determining the mean gradient is much less tedious if the echocardiographic instrument is equipped with a Doppler calculation package. In this case, the Doppler velocity spectrum has been traced and the instrument has calculated the mean gradient, 60 millimeters of mercury. In general, a mean gradient greater than 50 millimeters of mercury signifies severe aortic stenosis. It is critical that the gradient information which we report to the clinician is derived from the maximum velocity obtainable by Doppler. This will occur only when we have oriented our Doppler beam so as to minimize the angle theta. In order to accomplish this, we must inspect the valve for multiple transducer locations. In most cases, the maximum velocity will be obtained with the transducer either in an apical or right parasternal position. In about 15% of cases, however, the maximum velocity will be obtained from an alternate position. Therefore, we recommend that a methodical approach be utilized with inspection of the aortic valve from subcostal, right supraclavicular, suprasternal, and high left parasternal positions, in addition to the apical and right parasternal positions. This Doppler information was obtained from a 75-year-old female with aortic stenosis. A nice, complete Doppler envelope has been obtained using an apical transducer position. The spectrum has been traced. The maximum gradient is 108 millimeters of mercury, and the mean gradient is 64. The same patient was rolled to the right lateral decubitus position, and the Doppler transducer was tried in multiple right parasternal positions. The maximum velocity signal was obtained in the third intercostal space. This envelope is significantly larger than that obtained from the apical position. Here, the maximum gradient is 153 millimeters of mercury, and the mean gradient is 97. It is occasionally possible to visualize the jet of aortic stenosis with color flow imaging. This is most often accomplished in young patients using a suprasternal transducer position or, as in this case, a high right parasternal transducer position. From this position, the aortic valve has been identified by 2D echo, and the turbulent aortic jet was clearly identified by color Doppler. The color jet was then used to guide the placement of the continuous wave cursor. This patient has mild aortic stenosis with a maximum velocity of 2.8 meters per second. When the Doppler examination for aortic stenosis is performed methodically, an excellent correlation is obtained with gradients measured in the catheterization laboratory. In a Mayo Clinic study, Dr. Philip Curry examined simultaneous Doppler and catheterization data obtained from 100 adult patients with aortic stenosis. This is one example from his study. In this patient, the maximum aortic velocity was obtained from the apex and was 5.1 meters per second. This calculates to a maximum instantaneous gradient of 104 millimeters of mercury. The maximum instantaneous gradient from the pressure curves was 103 millimeters of mercury. Note that the MIG is greater than the cath peak-to-peak gradient, which was 87 millimeters of mercury. Not displayed here are the mean gradients, which were 74 millimeters of mercury from the Doppler velocity spectrum and 69 millimeters of mercury from the pressure curves. For the entire group of 100 patients, there was an excellent correlation between the maximum instantaneous gradient obtained from the invasive study and the maximum instantaneous gradient derived from the non-invasive Doppler velocity information. There was also an excellent correlation when the mean gradients measured in the cath lab were compared to the mean gradients derived from the Doppler velocity spectra. This figure from the same study illustrates the useful general rule that the mean gradient closely approximates the peak-to-peak gradient, with significant discrepancies occurring only when dealing with the highest gradients. Pressure gradients do not always accurately reflect the severity of stenosis. For a given degree of aortic stenosis, the pressure gradient will vary with changes in cardiac output. Therefore, in cases of aortic stenosis, we not only obtain the maximum instantaneous gradient and the mean gradient, but we also calculate the aortic valve area and the ratio of the velocity in the LV outflow tract to the velocity in the aorta. These last two do not vary significantly with changes in flow. The derivation of an equation for Doppler-derived aortic valve area requires echocardiographic determination of volumetric flow. You will recall from tape number 2 that volumetric flow can be determined by combining 2D and Doppler measurements. This is a schematic of a Doppler velocity spectrum from the left ventricular outflow tract. The area under the systolic velocity curve is referred to as the TVI, or time velocity integral. Integrating a velocity curve yields distance. Therefore, the TVI represents the distance that blood travels per stroke. If we measure the diameter of the left ventricular outflow tract by 2D echo, we can calculate its area. Multiplying this cross-sectional area times the TVI yields the stroke volume. In this schematic, the large A is the cross-sectional area of the left ventricular outflow tract, and the small a is the area of the stenotic aortic valve. The velocity and the time velocity integral in the left ventricular outflow tract are smaller than the velocity and TVI beyond the stenosis. The stroke volume will cross both the left ventricular outflow tract and the stenotic aortic valve during the ejection period. Therefore, flow in the left ventricular outflow tract must be equal to flow across the aortic valve. This mathematical expression, which equates flow in the left ventricular outflow tract with flow across the aortic valve, is referred to as the continuity equation. From the foregoing discussion, we calculate flow in the outflow tract by multiplying its cross-sectional area times its TVI. Similarly, we calculate flow through the aortic valve by multiplying the aortic valve area times the aortic TVI. Rearranging the equation, we see that the aortic valve area can be obtained by multiplying the cross-sectional area of the left ventricular outflow tract times the TVI of the outflow tract divided by the TVI of the aorta. It has been shown that the procedure for determining aortic valve area can be simplified without sacrificing clinical accuracy. Since the ejection time is the same in the LVOT and aorta, the peak velocities in the LVOT and aorta can be substituted for their respective time velocity integrals. This yields the simple equation that can be used in daily practice. The aortic valve area is equal to the cross-sectional area of the left ventricular outflow tract times the ratio of the velocity in the left ventricular outflow tract and the velocity in the aorta. Let us now review the method of calculating aortic valve area step by step, first in a schematic format and then with real-time examples. The first step is measurement of the left ventricular outflow tract diameter, which is carried out from the parasternal long axis view. The 2D image should be frozen in systole. For this, the continuous wave Doppler mode is utilized. While we are illustrating an apical transducer position here, you are by now well aware that the aortic jet must be interrogated for most of the previously mentioned transducer positions to ascertain that the maximum velocity has been obtained. Failure to obtain the maximum velocity spectrum will result in an underestimate of the aortic valve area. Once we have carried out steps 1 to 3 with meticulous attention to detail, we are ready to calculate the area of the stenotic aortic valve. As we noted before, the diameter squared times 0.785 is the cross-sectional area of the outflow tract. This is multiplied times the ratio of the velocity in the outflow tract to the maximum velocity in the aorta to yield the aortic valve area in square centimeters. Another potential pitfall when calculating the aortic valve area is in mistaking a signal of mitral regurgitation for the aortic stenosis spectrum. This error can be avoided by paying attention to the duration of the signals. As illustrated in this case, the systolic ejection period for aortic flow is significantly shorter than the holosystolic mitral regurgitation flow period. We will now review the 3 steps in calculating the aortic valve area using patient examples. This is a parasternal long axis view from an 87-year-old female with aortic stenosis. We will play this briefly in real time and then freeze the image in systole. The anterior caliper will now be placed here at the junction of the anterior aortic cusp and the ventricular septum. Now the posterior caliper will be placed here at the junction of the posterior aortic cusp with the anterior mitral leaflet. The left ventricular outflow tract diameter is 2.0 centimeters. This is a parasternal long axis view which has been expanded to focus on the left ventricular outflow tract. The aortic valve is densely calcified with greatly reduced mobility. The anterior caliper will now be positioned here. Now the second caliper will be positioned here. In this case, the left ventricular outflow tract diameter measures 2.4 centimeters. As you can see, the LVOT diameter can vary significantly from one patient to another. Remember that any errors made in the diameter measurement will be squared in the valve area calculation. It is a good practice to average the LVOT diameter from measurements on 3 separate beats. Having determined the LVOT diameter, step number 2 is to measure the LVOT velocity. This small 2D image is in apical long-axis format. The pulse sample volume has been positioned in the LVOT just below the aortic valve. The velocity at this point is 0.8 meters per second. To ensure that this is the correct velocity, we will now slowly advance the sample volume towards the stenotic aortic valve. This slight sample volume motion will result in a large increase in the velocity, which will be evident on the spectral and audio displays. This increase to 1.1 meters per second represents pre-stenosis acceleration and should not be accepted as the true LVOT velocity. We will now move the sample volume back slightly from the aortic valve. The slight motion of the sample volume away from the valve has resulted in a large decrease in velocity, from 1.1 meters per second back to 0.8 meters per second. From this, we know that 0.8 meters per second is the LVOT velocity that we should use in the valve area calculation. The third step in calculating the aortic valve area is to measure the maximum aortic velocity. In this case, all of the standard transducer positions were utilized. The maximum velocity was obtained from the right peristernal position, and the corresponding velocity spectrum is displayed here. The peak systolic velocity is 5.5 meters per second. This signal below the baseline is aortic regurgitation. This display will help you appreciate the range of aortic valve areas. Note that the base of this marker has an area of 1.22 square centimeters, which correlates with mild aortic stenosis. Contrast this with the cross-sectional area of the pencil, which is 0.5 square centimeters. This area correlates with critical aortic stenosis. Several authors have published their results comparing the aortic valve area obtained non-invasively by echo using the continuity equation with the valve area determined invasively in the cath lab utilizing the Gorlin equation. As you can see, the correlation has been uniformly excellent. These are the results that Dr. J.O. has recently published from a group of 100 Mayo Clinic patients with aortic stenosis. In this graph, the cath-derived aortic valve areas are plotted along the abscissa, and the echo-derived aortic valve areas are along the ordinate. As you can see, Dr. O's work in this large group of patients confirms the work of previous authors. The R value is 0.83. To be certain, there are a few discrepancies. Note that these occur with the larger valve areas. The discrepancies are partly due to technical limitations of the 2D and Doppler measurements. However, you should remember that the gold standard Gorlin formula is not a true gold standard. It is less accurate for aortic valve area than the continuity equation, particularly in the presence of aortic regurgitation or low output. The aortic valve area is most useful when the cardiac output is abnormally low or high. In such cases, the pressure gradient will not necessarily be an accurate reflection of the severity of stenosis. This patient has rheumatic mitral and aortic valve disease. The mitral leaflets are slightly thickened, and the anterior leaflet opens with a hockey stick configuration. The left ventricle is slightly enlarged. There is dense calcification of the aortic valve. In real time, you will see that the aortic valve has greatly reduced mobility, and there is severe reduction in left ventricular systolic function. We will now calculate this patient's aortic valve area. His LVOT diameter is 2.2 centimeters. Using the previously described technique, we have selected this sample volume position in the outflow tract. The LVOT velocity is 0.6 meters per second. For this patient, the maximum aortic velocity was detected with the CW transducer in the apical position. The maximum velocity is 2.8 meters per second, which corresponds to a maximum instantaneous gradient of 31 millimeters of mercury. When the Doppler spectrum was traced, the mean gradient was found to be 20 millimeters of mercury. For reference, the mean gradient, 20 millimeters of mercury, is listed. The LVOT diameter is 2.2 centimeters. This was squared and then multiplied by the constant, 0.785, yielding an LVOT area of 3.8 centimeters squared. The LVOT velocity, V1, is 0.6 meters per second. The maximum aortic velocity, V2, is 2.8 meters per second. This yields a V1 to V2 ratio of 0.21. In Dr. O's study, a V1 to V2 ratio of less than 0.25 was quite sensitive for detection of severe aortic stenosis. Like the aortic valve area, this ratio is independent of cardiac output. It is a useful index to follow in a given patient with aortic stenosis. It is also a very useful index to rely on when technical difficulties preclude accurate measurement of the LVOT diameter. The aortic valve area is calculated by multiplying the LVOT area times the V1 to V2 ratio. In this case, the valve area is calculated as 0.8 centimeters squared. Despite having only a 20 millimeter gradient, this patient has severe aortic stenosis. Given the accuracy with which echocardiography can now characterize aortic stenosis, invasive catheterization for valve hemodynamics should only be necessary in a very small percentage of patients. This would include the less than 3% of patients in whom the echo study is technically inadequate for determining a valve area. Catheterization will also be necessary when there is discordance between clinical data and the echo findings.